All right, I'm going to start because we have a little bit of a delayed start, but because at the request of the presenter, and as many of you know, there's a little bit of some slides here that I show beforehand. So before we get to our great speaker, Dr. Sheryl Green, we'll be talking about cognitive behavioral therapy for menopausal symptoms. I'd like to start with a land acknowledgement. We recognize that we work, live, play and participate in a community on unceded, ceded, and traditional territories of the 630 First Nations, each of which possess their own unique traditions and history here on this land that we now refer to as Canada. We acknowledge the importance of the Truth and Reconciliation Commission of Canada's call to action and the United Nations Declaration on the Rights of Indigenous Peoples. In all of the work, in all of our work, we are committed to ensuring Indigenous women's rights to health and safety and the equal opportunity to participate in a manner that recognizes and respects Indigenous cultures and traditions. Today, I'm joining you on from Toronto, which is covered by Toronto Purchase Treaty Number 13 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich the city. Many of our members also live in Vancouver, which is part of the unceded homelands of the Coast Salish territories, the traditional territories of Musqueam, Squamish, and Tsleil-Waututh First Nations. And I encourage you to use the chat feature to let us know where you're joining from today. I recognize that many of you are not joining from Canada. Uh, a little bit about the Women's Health Research Cluster. We now have over 750 members across 32 countries. So thank you so much. Together we will make a difference. I'm so excited to try and make a difference across globally. We have a number of different kinds of events, including the seminar series that you're at today. Please check out, we have a YouTube channel. Please check out our material on the new YouTube channel. Please join us, consider supporting us. And there is a trainee travel award right now. I think I might be wrong, so they'll correct me if I'm wrong. But it's probably due pretty soon. It's not a lot of money, but everything helps. It usually covers registration or so. And with that, I'm going to stop sharing so I can introduce Dr. Green properly, and she can start sharing her screen. Dr. Green is a clinical and health psychologist within the Women's Health Concerns Clinic and Sleep Medicine Clinic at St. Joseph's Healthcare in Hamilton, Ontario. Sounds like a really great clinic. She is also an associate professor in the Department of Psychiatry and Behavioral Neurosciences at McMaster University and co-director of clinical training for the PhD program in clinical psychology in the Department of Psychology at McMaster. Dr. Green's clinical area of expertise includes anxiety disorders, mood disorders, and insomnia. She is a fellow of the Canadian Association of Cognitive Behavioral Therapies and provides education and training in the use of cognitive behavioral interventions. Her research is supported by provincial and federal funding and primarily focuses on women's health. Yes. And the development of CBT protocols tailored to meet the unique needs of specialized populations. Dr. Green has published numerous research articles and is the author of two books, Cognitive Behavioral Therapy for Anxiety, Depression During Pregnancy and Beyond, and the Cognitive Behavioral Workbook for Menopause, a step-by-step program for overcoming hot flashes, mood swings, insomnia, depression, anxiety, and other symptoms. She's presented on her research widely. So we do welcome her. Cheryl, we're seeing your, the wrong display again.
Oh, we are. Okay,
Of
sorry about
course we are.
yes, yes.
It's okay. It says click to add notes. Shall we add notes for her? No. Thank you. Take it away, Cheryl.
Okay, great. Just get situated here. All right. Thank you, Dr. Galea, for your kind invitation to present on this important topic. I don't have any conflicts here to declare. And my outline here for this presentation includes highlighting some of the most common menopausal symptoms that women experience, treating these symptoms using cognitive behavioral therapy or CBT, a non-pharmacological approach. Though I am going to focus on CBT for vasomotor symptoms, more commonly known as hot flashes and night sweats. All right, well, as we all know, menopause is not a disorder or a disease, but a natural event that every woman who reaches the middle age stage of life here will experience. Puberty marks the time when significant hormonal changes first begin in life, signifying the commencement of female reproductive years. And similarly, the start of menopause, another significant hormonal shift takes place, and this time it's associated with the end of reproductive years. Estrogen and progesterone serve a number of major functions that including the activation of the menstrual cycle, which for most women is a 28-day cycle. There are a number of hormonal influences and fluctuations that occur within this cycle, and with that, women often experience negative symptoms, also known as PMS, which are considered a routine fact of life from ages 12 to our late 40s. Similarly, during the menopausal transition, which takes place on average for women between ages 40 and 60, many women here will experience a number of challenging physical and emotional symptoms associated with this transition that can significantly impact not only functioning but quality of life. And the ones that I have listed here are not exhaustive by any means, but they are ones I'd like to highlight because they are so prevalent. You can see, we start with, let's say, sleep problems, 61% up to 61% of women experience. Depression and anxiety symptoms at 52 and 68% respectively. Actually, for women going through the menopausal transition, this is actually considered a window of vulnerability for experiencing mood and anxiety disorders. Women are up to 4 times more likely to experience a depressive episode during this time than at other times in life, and 13 times more likely to experience depressive symptoms at this time of life compared to other times of life. Sexual concerns, wow, 68 to 87% of women experience this. So we're talking about difficulties with desire, arousal, pain, orgasm, satisfaction. And last but not least, our hallmark symptom of menopause, vasomotor symptoms, also known as hot flashes, night sweats. 80% of women experience this at some point during the menopausal transition. And since this is just a short presentation, I'm going to focus primarily on CBT for vasomotor symptoms. Since this is the most common symptom or hallmark symptom of menopause for women, perhaps I think people might be interested in learning how exactly can a psychological and behavioral treatment effectively target, treat hot flashes and night sweats. Can we think our way out of having a hot flash? Let's find out. So every woman's experience of menopause, really important to stress here, is unique, and symptoms vary from woman to woman, just like they do with menstrual cycles, with pregnancies, with postpartums. And we cannot solely take a biological approach to understanding symptoms and the unique impact that these symptoms have on each woman. And so what we do is we use the biopsychosocial model here to understand a woman's experience of the menopausal transition and the symptoms that they are experiencing. There are ongoing interactions with biological hormonal changes, psychological factors, and social context that go in to determine the severity, the frequency, and the degree of interference of each of these menopausal symptoms for each woman. So I'm going to try and play a video here. I'd like to stop share for a moment and share my video to hear a person with lived experience with the menopausal transition. Lisa, can you see this here?
I can see it.
Great, hopefully we can all hear it. Okay.
So how has the menopausal transition affected your view of yourself, your relationships, perhaps your view of the future?
I think I'm very aware of being middle-aged, and there's a sense of not being as vital, and I know that this is probably just an attitude thing on my part, but you know, when I was younger, I saw middle-aged women as kind of over the hill, almost asexual, And you know, I think our sexual identity, whether we realize it or not at the time, from the time of puberty on through motherhood and everything, is part of who we are. And when I got to that point where I felt that, not that I felt differently in myself, but I felt that I was being viewed differently by other people, I was suddenly like that, just that older woman.
I see.
And I felt devalued, and not a nice feeling.
Bring it back here to the screen.
Technical challenges.
Yes. All right. And all right. Is that looking good again, Lisa?
Looks great.
Okay, great. So I heard that this individual was very aware of being middle-aged, not as vital, over the hill, asexual. Not that she feels differently, but that she felt like she was viewed differently by others. She was suddenly that older woman feeling devalued. So in other words, folks, there's a lot of cognitions, thoughts, and beliefs that she shared about how she feels at this age, going through the menopausal transition, that are pretty negative, pretty inaccurate, and not so helpful. Can you imagine how these thoughts and beliefs are impacting how she feels about herself emotionally? So we have that connection with thoughts and emotions. She's pretty down in the dumps, feeling pretty hopeless. And also how these thoughts and beliefs might interfere with her life. Maybe she's not going to contribute to that discussion at work because she feels devalued, believing that others think that she doesn't have much to offer anymore. So in terms of treatments for menopausal symptoms, hormone therapy remains the most effective treatment for hot flashes, night sweats. And also selective serotonin reuptake inhibitors are very effective for depression and anxiety, sleep medications for insomnia, during menopause, outside of menopause. But for women who are not good candidates for hormone therapy and other medications because of contraindications, they're not able to take these meds. Importantly, personal preference, or taking the medications and not receiving the type of relief they want and need from their symptoms, still experiencing clinical levels of distress and interference. With all of this, there's a need for non-pharmacological treatments as an alternative or complementary therapy or treatment. And interestingly, I just finished a CBT for sexual concerns for women during peri and postmenopause. I want to share that half of my participants were taking hormone therapy, and 3/4 of them were taking an SSRI. So this is a perfect example of that item number 3 here, taking medications here, but not receiving the type of relief that they want and need from symptoms. So we need an alternative and or complementary therapy. Let's see. As a CBT researcher, educator, and importantly as a clinician, I can speak all day long about the benefits of cognitive behavioral therapy firsthand, having the privilege of witnessing a number of amazing outcomes in the patients, with the patients that I work with. CBT is a very effective treatment for a wide range of psychological and physical difficulties. Everything from depression and anxiety, those are first-line treatment for. Eating disorders, insomnia, chronic pain. And we see treatment gains that last not only post-treatment and 3 months post-treatment, we see them last to a year post-treatment. And I even recall a study looks at CBT for worry, and they reevaluated 8 years later, the gains were maintained. So as far as CBT for menopausal symptoms are concerned, a number of studies have been conducted targeting a wide range of symptoms, either individually, so CBT for insomnia during menopause, CBT for depression during menopause, or in the form of comprehensive treatment protocols. And I've included my own study here as an example. I conducted a randomized controlled trial evaluating my 12-session protocol where I targeted depressive symptoms, vasomotor symptoms, sleep, anxiety, and sexual concerns. And so either individual targeted symptoms or as a comprehensive treatment program, we see very, very good outcomes with CBT. And just a recent systematic review meta-analysis 2022 on CBT for menopausal symptoms. We had included 14 studies here showing improvements in a wide variety of symptoms and importantly, quality of life. So in 2023, the North American Menopause Society, now just known as the Menopause Society, released an important position statement on non-hormonal treatment for vasomotor symptoms. Although, as I mentioned, hormone therapy remains the most effective treatment for vasomotor symptoms, for women who are not good candidates because of the contraindications or personal preference, they recommend that CBT for vasomotor symptoms with a level 1 rating, which is defined as good and consistent scientific evidence. So the evidence is there, which is really, really encouraging. So when we want to start targeting hot flashes, night sweats here with CBT, it's very, very important to highlight what the goal is of treatment beforehand. And I come from a chronic pain background, managing chronic pain and using CBT. I see a lot of similarities here with vasomotor symptoms. So, I mean, CBT is very effective, but it's not necessarily going to take away the vasomotor symptoms completely, similar to an approach with chronic pain. Chronic pain is chronic. We're not going to take away the pain completely. So what we want to do is have the person that we're working with understand that we're trying to target a number of different aspects of the hot flash and night sweat. We're targeting the severity or intensity of it on a 0 to 100 scale, 0 not at all, 100 the most possible. Distress associated with the hot flash, 0 to 100 again. How much interference it has in our life when we're experiencing a hot flash. How long it hangs around for, and how frequent it occurs. And here are the active ingredients of a CBT for a treatment protocol for targeting vasomotor symptoms. So any CBT-based treatment protocol will include psychoeducation, awareness training. We can't effectively treat a symptom if we're not fully aware of it. Cognitive strategies, our thoughts and cognitions related to symptoms that we are experiencing influences how we perceive that symptom. Behavioral strategies, behaviorally, there are things that we can do that either help ourselves cope, but there's also things that we can do that makes the symptoms or problems even worse. This is known as maladaptive coping. Psychoeducation, this is a very, very big part I've found with all of the individuals I've worked with over the years, just getting an understanding of what the heck is happening and why to our bodies at this time of life. So having a good understanding, whatever it is that we're treating problem-wise or symptom-wise, having a good understanding of it puts us in a better position to be able to treat it effectively. So in this case, it would actually be very ideal to provide psychoeducation on the menopausal transition broadly and understanding why hot flashes more specifically occur, right? So having that understanding of the depletion of estrogen that occurs in the fluctuations of that hormone as it's being depleted over the years. Having that understanding puts people in a better position to just not, feel like they're going crazy or that their bodies are reacting in a way that's not normal. So for hot flashes, night sweats, what do we want to do here? Give them an understanding of what it is. So a spontaneous episode of warmth or sweating. Why does it occur? Dysregulation of core body temperature that results from faulty temperatures readings that are taken by sensors throughout the body that are thought to be influenced by fluctuating hormone levels. Lasting 1 to 5 minutes, can occur weekly, daily, hourly, and lasts on average a couple of years. And where does this fit into the hot flashes, night sweats fit into the CBT model? We have physical sensations of hot flashes influence how we think, feel, and behave, and we want to capture this with a hot flash diary. So in terms of a cognitive behavioral conceptualization of hot flash, if we're experiencing a hot flash, how we think about that hot flash influences how we feel emotionally, what we do behaviorally, and then how intense those physical sensations get does heavily depend on those thoughts and behaviors and feelings. So I'm going to give you a couple of examples of the exact same situation where two different women are experiencing a hot flash. So first one here, we have a woman at a dinner party, she's enjoying herself, great conversation, and all of a sudden she's noticing that she's getting very hot. Her thoughts in this situation are, this hot flash will last forever. This is so embarrassing, everyone will notice. Feelings that she's experiencing, stress, anxiety, loss of control. Physical sensations, heart racing, wave of heat, sweating profusely, and then behavior. She not only withdraws from the conversation, but she leaves the table and then decides to leave the party early. So significant disruption, interference with the activity that she's participating in. Let's look at woman number two. Same situation, at a dinner party, enjoying herself, having a conversation with a number of people, noticing she's getting very hot. Her thoughts are, oh, this hot flash will end soon, just like always. This is manageable, I can tolerate this. No one will likely notice. Feelings, uncomfortable, but in control. Physical sensations, heart racing, wave of heat, sweating profusely. Behaviors, just going to pause in conversation, engage in something called paced respiration. It's an effective behavioral deep breathing technique. Touching her cold beverage for a little bit of relief, but eventually she's going to re-engage and stay at the party. So, want to with those two examples, just demonstrate how our thoughts can really have an impact on the hot flash experience. Those thoughts are not so helpful with woman number one, a little bit more adaptive and helpful with woman number two. And behaviors, very disruptive for woman number one. She's left the party early. Woman number two, she's taking a break, she's cooling down, she's re-engaging later. I want to next just get to know Paula a little bit more. So the individual that I introduced to you in video a few minutes ago. So Paula is a 57-year-old happily married woman with 4 children. She currently lives with her husband and youngest son and has worked as an RN for over 25 years. Most recently in a unit requiring lead attire for certain procedures. Presently, she's having 2 hot flashes a day, but more at work, as well as 3 to 4 hot flashes at night. Just going to stop share for a moment and bring up that next video.
Okay, Pam, I was hoping you can tell me a little bit about how the menopausal transition has been for you and what type of symptoms you've experienced with it.
I think the biggest one for me was the hot flashes. That was, it just kind of came out of nowhere. I was probably into my 50s before they started, and I was thinking maybe I was going to get by without them because a lot of other people around me that were even younger than myself were experiencing them. And then they started, and they increased in frequency. I was getting them numerous times a day, and I found them very bothersome. I found them bothersome mostly at work. because I was sometimes in a situation where I wasn't able to control them. I was wearing lead because I work in an X-ray area, and I was wearing a lot of other clothing on top of the lead that was keeping heat in, because I work also in an area where there has to be a sterile environment. And I was just feeling so unwell and so hot and unable to escape the situation that it got to the point where I didn't want to do my job.
I see. Quite significant. So what do we hear from Paula in terms of her hot flash experience? Actually pretty interfering, pretty distressing to say the least. She initially thought that she was going to get by without a hot flash experience here in her life, and then they started. She found them very bothersome, interfered tremendously at work. I think we even heard her say that she was considering stopping work, which is incredibly interfering and just speaks to how distressing the experience is. Felt like she had no control over them, felt so unwell, felt so hot. So what do we want to do here first with a CBT protocol trying to target hot flashes? Again, we can't treat something effectively if we're not fully aware of the experience of the symptom. So what we do is have people complete hot flash diaries. So hot flash diaries help people describe the situation in which they're experiencing a problematic hot flash, how intense it was, from 0 to 100, distress, 0 to 100, capture emotions and physical sensations associated with the experience, and then importantly too, their thoughts and the behaviors, what they ended up doing when they were having the hot flash. So what we want to do later is analyze the entries together. And so first of all, just walking through these two situations, we have this woman writes, shopping at the mall in the afternoon with my daughter. The intensity was 50, distress 50. She was feeling frustrated, hot, sweaty, shaky, lightheaded, and her thoughts were, this is never going to end. Something's wrong with me. This is going to ruin the day with my daughter. And her behavior left the store right away. She took off her jacket and she walked outside to cool off. Next entry, contributing to an afternoon meeting with colleagues at work. Feeling intensity was a little lower at that time, 40, but look how distressing it was, 90 out of 100. Feelings were incompetent, embarrassed, hot, sweaty, lightheaded, and shaky, and thoughts were, everyone can tell that I'm having a hot flash. I should find an excuse to miss the next meeting. So she stopped speaking as much as she usually does, pulled her sweater closer on so that no one could see her sweat, and then took a sip of water. So hot flash analysis, we want to analyze the entries, as I mentioned, together, asking questions such as, were there certain situations that were more distressing for you than others? Were your hot flashes more intense at a certain situation than others? What was happening in those situations? What typical behaviors did you engage in when a hot flash occurred? Did they help or were they disruptive? So really getting that breakdown and that understanding of what they did and how it worked for them or not worked. And reviewing the diary, seeing a connection between their thoughts, behaviors, and feelings, and just really trying to capture some patterns as well. So we want to start equipping people with some very effective strategies. Paced respiration is something that we teach pretty much right off the bat. It is a slow, controlled, diaphragmatic breathing technique. Different people call it box breathing, belly breathing. The goal here is just to replace that chest breathing, shallow breathing, with slow, deep abdominal breathing. And this is a very simple technique, but it does require practice to master, so to speak. And we use it, well, I just Came from a perinatal anxiety treatment group, and this is what we had introduced as part of the content there to help with anxiety. So it does help with anxiety, tension, negative impact of a hot flash. So what are we doing? We're inhaling in an exaggerated way through our nose, count of 3 of 5 if that's comfortable for them, pausing for a moment before exaggerating that exhalation for, again, a count of 3 of 5 if it's comfortable, pausing and then engaging in the next cycle. This is a wonderful strategy because it's one that people can take wherever they are. If they're in that work environment, no one can tell that they're engaging in deep diaphragmatic breathing, paced respiration, and it absolutely does help. Other behavioral strategies that we introduce for hot flashes and night sweats really depend on what the person is describing from their hot flash diary. We'll talk about layering clothing, we'll talk about adjusting room temperature, modifying diet. This is an interesting one because we do know that spicy foods, different types of foods can initiate a hot flash, trigger a hot flash. So we'll look at a hot flash diary to see if there's any kind of connection there. Using cold devices. Ooh, we've become very, very creative with those types of devices, and I've learned a lot from the patients and clients I've worked with. So for everything from putting a bottle of water into the freezer at night, pulling it out right before they leave out the door for work the next day, and having that handy in their work bag to just touch whenever they need a little bit of relief. Had people, let's see, oh, this is a good one here too. Take a bag of peas, and a frozen bag of peas, and put it in a Ziploc, stuff it under their pillow, and if they have a night sweat in the middle of the night, they turn that pillow around and it's nice and cool. They get that kind of relief from the bag of peas that's been under the pillow. So adjusting bedroom environment and adjusting activity level. This last one will become a little bit more clear with an example I give. All right, so women are instructed here to capture the use of their behavioral strategies. We always want to be able to see if a strategy that has been introduced is effective. So we ask them to treat it like an experiment, really put thought into whether or not it helped. And this can be very reinforcing exercise, as it requires one to be very mindful of the outcome, right? What they're doing differently and what kind of impact that it's having. So looking at this, these situations, shopping at the mall with my daughter in the afternoon, behavioral technique chosen, plan clothing in advance, make sure I'm dressing in layers so it can be adjusted as needed. And then what was the outcome like? Well, she felt cooler when she got out there and had a sense of control over the situation, which sounds like both a nice behavioral strategy outcome, but also from an emotional perspective, feeling that sense of control. Wednesday, contributing to an afternoon meeting at work with colleagues, stopping at the water cooler before, filling up a cold bottle of water, paced respiration before and during the meeting, in between my turn to speak. She felt somewhat less sweaty, relief from the cool water, less anxious about presenting. We're not trying to accomplish complete lack of distress here, no anxiety, no distress at all. We're trying to have these situations become more manageable, more tolerable, and less interfering. Last one here, Friday morning, getting ready in the morning on my way to work. Plan to wake up 30 minutes earlier to give myself some more time to get ready, reduce my activity levels just before leaving the house. Because she knows that rushing, that fast pace in the morning triggers more hot flashes. Also engaging in paced respiration. And so she reported it gave her a greater sense of calm and ability to cope. And then finally, cognitive strategies here. This is really the meat and potatoes of cognitive, of the C in CBT, where we ask women to write down their thoughts associated with the hot flash, just like we did with the hot flash diary. But this time we want to have them examine if there's any distortions or thinking errors present, thoughts that aren't helpful. So we are introducing that idea of what a thinking error is, or a cognitive distortion, if we want to be fancy, call it that. And then really getting them to look at their thoughts, to examine, again, how accurate are they? How helpful are they? And we enlist questions rather to challenge those identified thinking errors and come up with ones that are more helpful and effective coping statements. So this is what a hot flash thought record looks like. So very similarly, we're having people, similar to the hot flash diary that is, write down the situation. So contributing to an afternoon meeting with colleagues at work, write down what they're feeling: anxious, embarrassed, sad, frustrated, and what are their thoughts. Everyone can tell I'm having a hot flash and will think that I'm incompetent. I can never cope with my hot flashes. And very commonly that I've seen, this will never end. Well, I will always have to deal with this. So after examining together some of these thoughts, cognitive distortions, also known as thinking errors, have been identified with some mind reading, negative filter, and catastrophizing. So what do we want to do at this point? We want to start to question and challenge the unhelpful thinking. Based on my experience, for instance, how long do my hot flashes really last? If I remember that they're 1 to 5 minutes, as opposed to like this is going to last forever, that might be more helpful to bring into my awareness at that time. What strengths and coping abilities do I have to help me manage my discomfort and distress in these types of situations? So remembering what I've done in the past, what's been helpful, and actively bringing that back to the forefront of my mind. So hot flash thought record, that's complete with the balanced thoughts or alternative thoughts. Include some might notice, but most are likely unaware of my hot flashes and have not judged me or said anything in the past. This is uncomfortable, but I have effective strategies that have worked in the past that I can use to manage, like holding a frozen water bottle, paced respiration. Although uncomfortable, my hot flash tends to be brief, a few minutes. They will become less frequent and intense over time. I just have to stick this out. So you can see how those particular thoughts, balanced alternative thoughts, can be very, very helpful and very different from some of those original thoughts and predictions. All right, folks, I have one more video to show because I would love to have you learn about the outcome with Paula here. Let's bring up this last video.
So Pamela, how have the cognitive behavioral therapy sessions helped with your menopausal symptoms?
Well, I've noticed a big change in the way I'm experiencing my hot flashes.
Okay.
It took some time. It was gradual, but I became more aware of my ability to change my attitude toward them more than anything. There were some physical things that you helped me with, and it became very natural to me to just breathe deeply, slow, deep breath, measured breathing. I did that over a period of time, and before I knew it, I was doing that unconsciously, not even really aware of it. I was just starting to have a hot flash, and I was just doing this breathing, and it was helpful. And then it got to the point where I almost wasn't as aware of my hot flashes. I was still having them. I was still having them a few times a day, and sometimes not in very ideal situations. But I found myself just kind of ignoring them, and I would do something about it if I was scrubbed at the table at work. I had a basin with some saline in it that I would just put my hands in, even though they were gloved, and they would cool my hands down. If I wasn't in a situation like that, I would find myself opening a window or taking something off, but it wasn't the same sense of urgency and panic and, oh, this is happening again. It was more a sense of, I'm just doing something about this.
Very good.
And to the point where, you take off your sweater and you move on, or you're charting and you just are aware of it, but you're not aware of it. And so I have found that has become who I am now.
Yeah, you've really adopted that into daily life and noticed a significant change.
That's right.
Distress. Yeah, not necessarily that the hot flashes are gone, but that you're coping with them and managing them much better than you were.
That's right.
Okay. So Paula here we can see is noticing quite a big change in experiencing her hot flash, ability to change her attitude towards them. And just notice how she's speaking. She's having a hot flash and engaging in breathing. She's still having hot flashes, but found herself ignoring them or doing something about them that are effective without that same sense of panic or urgency. I think that's a really important part there. It wasn't so gripping when she experienced them. She noticed them, she would do something about them, and she'd continue with whatever task or activities that she was participating in. So quite a difference. So in summary here, every woman's experienced menopause and associated symptoms is unique, best conceptualized through this biopsychosocial model. And many common menopausal symptoms can be effectively treated with medication, but CBT is an effective non-pharmacological alternative or complementary alternative for those who can't or prefer not to take medications. And the strategies for hot flashes, night sweats include tools such as hot flash diaries, thought records, behavioral experiments, in addition to psychoeducation. And I'm just going to put a shout out to psychoeducation. I can't believe how significant a component that is for women who are going through the menopausal transition. Just that understanding of what this transition is, why it occurs, what's to be expected, and then equipping people with the right tools and strategies to work with those symptoms. That's it. Thank you very much.
Well, thank you so much for those of you that are online. Well, everybody's online, I suppose. Yes, thank you, Laura, for giving us the little emoji. It's just fantastic. It's always nice to have a little emoji just so that we know that we've reached people into the cyber universe that's out there. So I know that Dr. Green really appreciates it. I appreciate it as well. I have some questions, but I also forgot to give the fun fact. Because some of you will know that I like to give a fun fact about our famous researchers that come and give us their time and educate us about all sorts of things. And Cheryl's fun fact is that as an undergrad, she spent 4 months, and I'm not going to be able to say all of that, but she spent 4 months on Vancouver Island, which is amazing. I don't know where you did your undergrad, in Ontario?
Saskatchewan, actually.
Oh, Saskatchewan. Saskatchewan. So she moved to Vancouver Island for 4 months and was in three beautiful locations, Rocky Point, Bainfield, and how do you pronounce the last one?
Oh, the beautiful temperate rainforest of Carmana.
And guess what she was doing there? She was catching and handling bats. That's not for everyone, but bats are actually super, super cool. I learned about them in undergrad too. But we're very appreciative that you chose to do clinical psychology instead of behavioral ecology or whatever you were doing there. I mean, I have so many thoughts. Thank you. I also wanted to thank Paula for giving permission to have those videos. That was really, really great. And if people have any questions, please put them in the chat or, oh, here's Daisy has one. I guess I should go to Daisy first. Daisy, do you want me to ask your question? We can read it out. for you. First of all, she says that was great. Can you speak to any data of cultural differences for women of color? A really great question. Or marginalized communities in the space of peri and menopausal symptoms and CBT strategies? I can imagine that culturally there's a huge difference. And obviously with people of color and marginalized communities too, there should be differences as well. Yeah.
Yeah, I do know that for vasomotor symptoms in particular, that there's, I think, Black women experience more tense, more debilitating, interfering symptoms. And also know that this is actually a bit of a problem is being able to capture right now people who are from diverse backgrounds and cultures, and that I just completed a study, as I mentioned, CBT for sexual concerns for peri and postmenopausal women, and it was pilot. Great results in that, but like over 80% of my participants were white, were Caucasian background. And so just put in a grant application with part of our methodology specifically targeting for different groups of ethnic groups and cultural backgrounds to just have that representation, because we want to be able to see what types of treatments here are effective for not only people from one background, but many backgrounds.
But yeah, and I can't really completely answer this, but I have heard that for certain cultures there is no talking about, hot flashes or night sweats. So I'm just wondering if it's even more helpful or even more difficult to engage, which is what you're talking about in terms of recruitment, I'd say, for those different communities. I don't know if you know. I can't remember which cultures they are, so I don't want to say something specifically when I'm not really sure about.
Yeah, no, I completely agree. I have on my research team now a person with ethnicity, cultural specialization background, and to help me recruit
Yeah.
in a way that is culturally sensitive and so on, just because of course, we want to be able to reach as many people as possible with treatment programs that are effective. So.
Mhm. Yeah, it's always a challenge, but always so important to keep going. Gabriella has a question. Thank you for your talk. Do you have any advice on how to encourage a woman in menopause to go to CBT or even start taking medication? And actually, if I can add on, Gabriella, to yours, I was thinking, um, you know, uh, for lots of different things, just because you're taking medication doesn't mean might diminish, but it might not completely go away. So CBT actually, because you were sort of using it as an and or, but I think like it can be an and, right? I mean an or, but it can be an and as well.
It definitely can be both. I think when I first started the Women's Health Concerns Clinic at St. Joe's in 2006, it was very striking and just completely unacceptable for me to see that there was no psychological and behavioral, non-pharmacological, let's put it that, interventions that we were offering that was widely used out there. And so that's why I started to build. It was just, to me, that's not acceptable. But I quickly learned here too that a lot of people who, when I was recruiting for my CBT studies, they were taking medications, hormone therapy, even SSRIs, as I mentioned, and just not receiving the type of relief from symptoms that they are striving for, and still with symptom measures at clinically significant levels of distress. And so this really does speak to the fact that we do need a complementary form of treatment as well. And that's not uncommon when we see, folks who are, like I just had a CBT for parent anxiety treatment group I was running. Every group that I'm in, roughly half of people are taking an SSRI, right? That's not uncommon, and research shows that produces the best outcome. A CBT and medication together,
Combination. Yeah.
or the
Yeah,
combination.
even menopausal hormone therapy, even though it is probably the most effective for vasomotor symptoms, it doesn't eradicate them. It's not like you're going to have zero. Speaking also from anecdotally from personal experience, I still have night sweats. Um, but how would you encourage people to?
Yeah, I think it's very interesting. Again, in my own experience, when I'm recruiting people or just receiving them to provide clinical services in women's health, concerns clinic, a lot of people like even start by saying, I really don't want to take medication. So it's not sometimes very
Yeah.
hard to
Yeah.
have people come over to this side and engage in this type of research, or sorry, this type of clinical work. What is so having that openness to just to dig in your heels though and engage in some of the work that's associated with
Yeah.
cognitive behavior therapy, that's something that I'm very transparent about right out of the gate, no matter what treatment group I'm running. Last week I just started a CBT for menopausal symptoms treatment group, and I told them this is what you can expect: a lot of work. You're going to get a lot out of these 2 hours when we work together here. But everything that I give you for home practice exercise, you have to engage in the home practice exercise to see, the different progress with your symptoms that you want and need. So really being upfront, and I think people like they want to do that. A lot of people want natural approaches here, and this is definitely one.
Mhm. No, I completely agree. There was a question about neurodiversity from Catherine Crawley. So I'd like to know about the impact of CBT on neurodiverse populations. Do you know any data? There
I
might not
don't,
be.
and I will kind of offer here, folks, that even the field is expanding. Like there's more and more research that's being conducted, but I would still say that it's still
Oh,
kind of
it's low. Yeah.
yeah.
Let
So
me just say,
yeah,
just like it's under 2%. So it's great even if it doubles. Like maybe it's going to double, but
yeah,
that's really, 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 we're talking about really low numbers. So all of it's needed. So I know that probably many of your Instagram pages and social media are filled with stuff, but it's still, yeah. No, great answer, Cheryl.
no, and I appreciate that because we need that. We absolutely like more culturally diverse, more all of that research is needed, 100%.
Selena asks, in your experience, what do you know about how strong the relationship is between hormone changes and mood disturbances versus the woman's cognitive emotional response to other changes like vasomotor or sexual difficulties?
Yeah, so that's all interconnected. We know that hormones influence the emotion regulation system of the brain, right? The limbic system. And so if there's changes happening, fluctuations especially, that's going to affect how we feel emotionally. And over a lifetime to that point, 40 to 60, we've kind of engaged in different ways that we work with and cope with our emotions, and it developed learned ways to do that either maladaptively or adaptively. So I think that the person ideally who has learned how to work with their emotions well in an adaptive way over the course of their lifetime until that point are going to be in a better position. But it's tricky, like it's so important to recognize that it's not necessarily this situation or your lack of coping strategies when you're experiencing these changes in emotions. So just that awareness, that recognition, and then proceeding to engage in a helpful adaptive way. I think you're at a little bit more of a person's at a little bit more of in a tricky situation if they have had more maladaptive ways of coping and responding to emotional difficulties. That does then put you a little bit more at increased risk of experiencing significant mood anxiety difficulties during menopause.
One of the things I noticed was, you had something about like, oh, there's more, whoever it was had experienced more hot flashes when they were at work
Yeah.
a day. And I thought, oh, so stress obviously is increased. And then if you've got something, you got something going on, you're racing out the door, you're going to experience more likely to experience, I guess, a hot flash. And so that relationship too is really interesting.
For sure. I'd say I have about a group of 10, 11, or 10 to 12 people in my menopause group. And I just remember hearing a couple people's experience of like, when I'm feeling anxious, I get more hot flashes.
Right.
I have a hot flash, I get more anxious. Like there is this
Right.
connection. Absolutely.
Yeah. And so that's so, I mean, because CBT will help with that anxiety, of course. Okay. There's not enough questions, but there's so many questions.
Good.
Which is great, which is fantastic. And many people saying thank you very much. Courtney's asking, can you speak to the mechanism of change with CBT for vasomotor symptoms? The mechanism of change, like how?
Yeah, I just think that again, the way that we are interpreting the experience of a hot flash. So all of this, the physical experience of hotness and such, and what we can, how we can control it or work with it, that's going to either prolong that hot flash experience. It's going to create more distress if we have certain cognitions, as just making reference to that example in my presentation, or the opposite, right? If we have like, okay, no one likes a hot flash, but if we have a different approach to it and think to ourselves like, I love this one person in particular I worked with. She's like, "Oh, I'm having a tropical moment right now, and I know that this will pass. I'm just going to engage in my paced respiration. Actually, where's my cold device? And actually excuse myself to just grab a tissue, come back, whatever is needed. And I know that it will pass, and I'll be able to engage again. Not a big deal."
Yeah,
Yeah.
yeah, go ahead. No.
You have an experience like that, the distress is low, the control is high, the hot flash has the potential to like have a shorter duration, and so on.
Yeah, I was just going to say, I'm sure, that sort of, even though somebody's saying that respiration, and we'll get to that in a second, isn't recommended by the NAMS or something, but so we can get to that in a moment. But I know that CBT also can alter like functional connectivity in the brain, and it's like it's basically thought patterns and stuff. So you can reactivate or what's the worst, deactivate. It sounds very sci-fi, but different regions of your brain to sort of reprogram the way you're thinking, essentially.
Love the word pre-program. That's exactly what I see, how I view it as well.
Yeah.
And yes, for whoever it was, it kind of pointed out that paced respiration isn't recommended by NAMS as a standalone treatment. So incorporated into a
Right.
protocol for hot flashes, night sweats within CBT, then it is. That's part of it.
I'm skipping Laura's question, but I'll come back to it because I think we'll have time for it anyway. Because I think this is really, Catherine also says, look, CBT in Europe is too expensive for many women. Oh, and NAMS is North American Menopause Society. Somebody was asking what that is. CBT is too expensive. So data in Ireland, there's scarcity. So are there any online resources that exist for people that are in lower income or in countries where it's not offered?
Yeah. I completely appreciate that, and I am doing a little bit of what I can as a one individual here. I'm hoping others will follow.
But you're only one person.
Only one
And you're in
person.
Hamilton, Ontario.
I know. I'm extremely feel strongly about self-help materials and that. So I had that one self-help book that was out. I have
a book.
I have another one coming out, updated, etc., with also a clinician's guideline, so that people can just take that and engage with people that they're working with, or you can get onto Amazon and you can kind of read through this stuff. Like I said, psychoeducation is a huge component of any CBT program, but I think in particular for menopause, people understanding what's going on with their body at this time. So I totally appreciate that. CBT, it is expensive, and it's just about trying to get resources to people so that they can do a bit on their own as well, or that if they have the luxury of working with someone, there's some proper evidence-based resources that are out and coming out too.
Now I think we have time. We have 2 more minutes. So just Laura has a great question too. Thank you for a great talk. Lots of them are saying that, by the way. Does the CBT intervention for hot flashes have lasting effects? For example, is it related to less brain fog or memory disturbances, less sleep disruption, or even a shorter duration of menopausal hot flashes that are experienced? Do you have any data on that?
Well, I don't have data on, but I'm just going to speak. What's one thing I did not talk about that is a very hot topic and a very common experience is the brain fog, cognitive difficulties, and which is a very real thing. There's, again, in my groups, I have just as of late, a lot of people very anxious about thinking that this is early onset dementia. I'm co-leading with a clinical neuropsychologist right now who's I co-created with her a cognitive remediation program for cognitive difficulties like this for menopausal individuals. And just giving different skills and tools and strategies and confidence about their cognitive abilities, knowing that the data is showing the likelihood of it kind of rebounding, being able to, as Lisa knows, kind of come back again, and not to fret, not to reduce or to reduce anxiety. But back to now, I forgot the original question there. Lisa, you're gonna have to help me
Is
out.
there like does it have lasting benefits on like sleep, or short or even shorter duration of vasomotor symptoms?
CBT?
Yeah,
Uh, CBT definitely has, yeah. So we didn't even touch on sleep either. My apologies. I'm used to giving like half day or full day
I
workshops.
know.
I'm so sorry. Sleep, absolutely. There is data specifically CBT for insomnia, sleep difficulties within menopausal population. Very effective. Those active ingredients, guys, the time in bed restriction, stimulus control, being able to again understand concepts and theories like sleep drive and that, giving all the good content there, but also appreciate it in the context of menopausal transition. So adding more behavioral strategies in, like I said, the frozen peas in a Ziploc under the pillow, and having another set of jammies right beside your bed so you're just less disruptive. All of these things, but CBT very effective for that as well.
Well, with that, thank you. I want to thank you, Dr. Green, for your excellent talk. Obviously, we really need these kinds of talks, and I'm glad that the conversation is growing in this area. Let's keep it going because, right, 50% of the population will go through menopause at some point in their life. And it's just really important to talk about it, right? Psychoeducation. So thank you again for your time. We really appreciate it and for breaking open the conversation for us.
Great. Thank you for having me
And with
and
that,
with this important topic. I so appreciate it. And thank you so much, everybody, for attending. I appreciate your presence here.